Welcome, ladies and gentlemen. In the following few minutes, please let me introduce you my PhD work, which is about a translational approach for better awareness of cystic fibrosis-related glucose abnormalities. As well as I'm a PhD student, I'm also a pediatric resident who is involved in the clinical care of patients with cystic fibrosis. Therefore, my vision and my mission is to improve the life quality of these patients by applying up-to-date scientific results in the clinical assessment of cystic fibrosis-related glucose abnormalities. To estimate the significance and to assess the prevalence of its local and global prevalence, we conducted a cohort study and a meta-analysis in this topic. The life expectancy of cystic fibrosis increased in the past decades thanks to new therapeutic options. Therefore, complications that need time to evolve, such as osteoporosis or our interest cystic fibrosis-related diabetes, have come into light. But we have to think about diabetes as the end stage of a progressive disease, the abnormal glucose tolerance spectrum. Before diabetes, there are prediabetic conditions, such as impaired glucose tolerance or indeterminate glycemia. Basic scientific research that this prediabetic condition starts at very early ages, and the diagnosis of abnormal glucose tolerance is known to be associated with increased morbidity. However, oral glucose tolerance test, which is still the gold standard method for diagnosing this glycemia, is only recommended from 10 years of age. Therefore, the characteristics and dynamics of the progression between the different glucose tolerance status is still unclear. That's why we wanted to know what is the prevalence of abnormal glucose tolerance in different age groups of cystic fibrosis, especially under the age of 10. After the selection process, we included 457 studies in our study. Due to the vast amount of data, we investigated several outcomes regarding the whole spectrum and each of its subtypes. The size of the circle and the number in it represents the number of the included studies in each outcome. Now I would like to show you the most important ones, signed by the red circles. Firstly, we examined the prevalence of cystic fibrosis-related diabetes. According to the results, the prevalence was 9% in the pediatric and 27% in the adult population. There is a visible tendency in the increase of the proportion in the pediatric subgroup, with approximately 0% in the 0 to 5, with 5% in the 5 to 10, and 11% in the 10 to 18 years of age subgroup. Interestingly, the prevalence of prediabetic conditions remained unchanged through time, with approximately 20% regarding impaired glucose tolerance, even under the age of 10, and approximately 15% regarding indeterminate glycemia. Examining the whole spectrum of abnormal glucose tolerance, encompassing each of its subtypes, we found that a third of the children with cystic fibrosis are affected by abnormal glucose tolerance, which increases significantly to 51% by adulthood. Please let me show you the diagram which represents the risk as a function of age to have diabetes. As you can see, the risk to have diabetes increases with age most rapidly during puberty, but that increase starts early, before the age of 10, and is only the end stage of this progressive disease. In conclusion, we can say that abnormal glucose tolerance affects every second adult and every third child in cystic fibrosis, and prediabetes is frequently present before 10 years of age. With early detection and treatment, these children have the best possibility to prevent all the adverse consequences of an uncontrolled glycemic status. So it's time to reconsider the current guidelines and start screening for abnormal glucose tolerance no later than 5 years of age, and then start dietary intervention as soon as possible. And there is an urgent need for a patient-friendly screening method which is suitable even for toddlers who cannot drink the sugary liquid needed for OGTT. Here is the current status of our manuscript. It's submitted and waiting for evaluation at metabolism. What is the prevalence of abnormal glucose tolerance in Hungarian children with cystic fibrosis, and what happens with them after the diagnosis? These are the questions that can be answered from the data of the Cystic Fibrosis-related Pancreatic Disorder Registry. The registry's aim is to assess the prevalence of this glycemia in our registry patients, especially under the age of 10. Currently, we have analyzed the first 117 patients who were able to undergo OGTT who were previously diagnosed with cystic fibrosis-related diabetes. The long-term aim of this prospective study, with yearly follow-up visits and yearly re-evaluating the abnormal glucose tolerance spectrum, is to earn knowledge about the progression between the different glucose tolerance status. As you can see, we have 4 years of follow-ups, and now 101 patients are active in the registry. The OGTTs are performed for 3 hours with measurements in every 30 minutes. Why it is important? Because the 2-hour OGTT with 2 time points, one at 0 and one at 2 hours, has been extrapolated from the OGTT cutoffs intended to detect type 2 diabetes and these obesity-related prediabetic conditions, and may not be optimal for diagnosed cystic fibrosis-relevant clinical decline. However, the OGTT with interim time points may be better suited, as the 1-hour glucose elevations has been associated with decline in the pulmonary function. It's more impressive when we visualize the glucose concentrations during the OGTT with 2 time points and with interim time points. As you can see, in the first case, only impaired glucose tolerance can be detected. However, the intraterminal glycemia group, which spent more than an hour above 11 millimole per liter glucose concentration, would be unrecognized due to the normal values at 2 hours. However, these high values and the reactive hypoglycemia at the end of the OGTT after 2 hours suggest an abnormal glucose metabolism. If we visualize the prevalence of abnormal glucose tolerance, we can see with interim time points and the diagnosis of intraterminal glycemia, 4, 25, and 11% more children with cystic fibrosis was diagnosed and started therapy to delay the onset of diabetes and delay the disease progression. To determine whether a native sugar-free diet or insulin therapy is needed, those patients who have them more than 2 interim blood glucose levels higher than 11 millimole per liter was further examined with a preponderantly point-of-care technique, capillary glucose monitoring, and with a consultation with the endocrinologist. Thanks to these examinations, you can see that 9% more and 2% more and 5% more per patients with abnormal glucose tolerance was diagnosed with diabetes and started insulin therapy before any complications of diabetes. In conclusion, we can say that abnormal glucose tolerance affects every third children in our patients, and prediabetes is frequently present before 10 years of age in our cohort 2. With only OGTT with 2 time points, 32 cases of the abnormal glucose tolerance cases would have been missed. With OGTT with interim time points without pre- and postprandial glucose monitoring, 31 cases of the diabetic cases would have been missed. So our protocol would be better suited for early detection of cystic fibrosis-related abnormal glucose tolerance as the gold standard, and may be a potent alternative to continuous glucose monitoring in low and middle income countries where it's less available. Here is the current status of the registry. We analyzed several data, but we need to do more. And the results of our cohort analysis harmonize with the results of our meta-analysis, since both underline that abnormal glucose tolerance is highly prevalent in cystic fibrosis, even under the age of 10, where current guidelines do not recommend screening. However, early diagnosis and treatment is crucial, as an abnormal glycemic status leads to rapid clinical decline. With the list from my additional activities, you can get the whole picture from the result of of my PhD, because, as Winston Churchill once said, however beautiful the strategy, you should occasionally look at the results. Thank you for your attention.
So congratulations for the nice presentation. My question is that nowadays the CFTR modulators are available in Hungary as well. Do you have any experience if these drugs have any effect on the endocrine function of the pancreas in these patients?
Thank you for your questions. 2 years ago, we started the ivacaftor lumacaftor double therapy, So we have long enough data with them, and we do not really find any difference in the glucose metabolism. Maybe more time can bring something. With the triple therapy, the elexacaftor, lumacaftor therapy, ivacaftor therapy, we only have less than a year of experience, so we cannot conclude anything from that short time. But the international results suggest that the triple therapy improves not only exocrine pancreas function, but the endocrine pancreas function as well.
Nice talk. Congratulations. OGTT is a very time-consuming process. Is there a role for hemoglobin A1C in the assessment of these glucose abnormalities? What do you think?
We also measure hemoglobin A1C in every year, so the yearly follow-ups. Beside we do GTT, but we do not reveal any association between the progression of the different glucose tolerance status. So, and the international studies also said that it's not the optimal for screening glucose tolerance status.
Thank you very much. Really wonderful work, and I think it will really change medicine because the younger age, we did not think it has these problems. Do you think that even very small babies, you now have here the neonatal screening program, just to do a fasting glucose on a baby with CF, do you think that could be your next project?
Maybe. It's much harder to do research in little babies. Maybe fasting glucose can be an option, but it's usually not harmed in the first phase of the glucose tolerance status, so it's not optimal for screening young ages. So that's why maybe continuous glucose monitoring, even in younger patients, can be the optimal for screening, because we can monitor the postprandial glucose elevation, which is the earliest abnormalities in the abnormal glucose tolerance spectrum.
Right, but we said that below the age of 10 it wasn't going to happen. You've proven that in the very young children it also happens. So I think you should mention that in the discussion. And also I think you should send it to the Journal of CF, by the way. What are those metabolic journals?
Yeah, it's also, if its metabolism doesn't accept it, then the Journal of Cystic Fibrosis.
So I have a technical question I have to ask. So in the first project, I've seen that you spend a lot of time about age groups. And my question is, were there any multiple entries from the same study? And what could be the problem with that?
Yeah, we have used multiple data from one study. The problem with it is we know it's clustered, but the good side of this, that both of the categories, so the age and the glucose tolerance spectrum, they either in one or either in the other, so they cannot be in both. So it's not that a confounding factor.
Thank you very much for your really, really nice presentation. Maybe I'm not too up to date with how much glucose should we give to these very little children during the OGTT. Is it the same as we give to older ones? Or?
No, it's pro weight kilograms. So it's 2 grams per 1 weight kilogram. And the maximum is 75 grams.
Okay, thank you. This was all.
Thank you, really nice presentation. My question is regarding with the CFRD relative risk age diagram. There is an increase at the age of puberty. What do you think? What can be behind that?
One thing that we experience decrease in every aspect, every clinical aspect, so not just in the endocrine pancreas function, but for example in pulmonary function when the teenagers are coming. Maybe because of the hormonal changes, so that's one possible answer. The other is the changing body type, the changing pulmonary status, and the other one is the change in compliance, because there is a decrease in compliance when puberty it comes, like in everything, so it also can be an answer for that.
Congratulations for your nice presentation. You mentioned a reactive hypoglycemia at the end of the OGTT. How serious was it? How serious was the symptoms? Did you have to stop the OGTT because of this?
Some cases we have to stop them. So if the patient experience clinical symptoms, so dizziness, sweat, they stop the OGTT and drink sugary liquid, or they start to eat to cure it. But the interesting thing is that they do not really experience any clinical symptoms. So between 4 and 3 millimole per liter glucose concentration, they are completely fine. And after the decrease below 3 millimole per liter glucose concentration, they start to experience something. But they are not so severe that we expect from that low glucose levels. It may indicate that it's a chronic progression, and they get used to it. Most of the patients usually tell us, oh, that's hypoglycemia symptoms. Yes, I have already experienced it in my lifetime after a big meal or something like that.
My question is, you have one paper submitted, which was already reviewed and now it's resubmitted, and the second one is under preparation?
Yes.
Okay. Thank you.